Would you guys call anything?
God, is that also taken?
I don't know. You tell me.
Oh boy.
I know, right? It's humbling. I'm telling you, the stomach is like super humbling.
I know it's hard.
This one's at least better distended, so at least you can say, given the degree of distension and the irregularity of the wall, maybe it's suspect, but and it's got a little heterogeneity, like right there.
Yeah.
It almost looks like it's got an ulcer in the wall or something.
Yeah.
And that's okay too, right? Like, is it inflammatory and ulcerated? Then they did an endoscopy, or is it ulcerating because it's a tumor and then they need to do endoscopy?
Yeah. Yeah, I don't know. I mean, prospectively, they're so hard. I mean, I respect the stomach so much. I think it's very hard. So in this case, that's what it turned out to be. It was gastric cancer. And so this was
terrible.
The patient had PET, which they do now, just to, before adjuvant. It's neoadjuvant, and then the patient had a post PET, and then there's that's not it. Post is here, and the FDG activity completely resolved, so that's a very good prognostic marker before the patient gets further resection. So this is a case of esophageal gastric cancer. And we discussed before about like, when do you consider something an esophageal versus a stomach gastric cancer? And it's because there's like a difference in prognosis. So adenocarcinoma of this region, esophageal gastric junction, they have lower survival rates compared to other types of gastric cancer. In this case, we would call it stomach cancer because the epicenter is in the stomach, like within 5 centimeters of the stomach, without extension into the distal esophagus. So if it was extending into the distal esophagus, then it would be an esophageal CA, but this isn't. So this is a gastric cancer that I think it's really hard to pick up prospectively.